So, a very good morning, one and all. Um, I will take the privilege to welcome you all to this session titled Decoding Cornea for the General Ophthalmologists. And among the dignitaries, we have Dr. Paras Mehta on chair, Dr. Nikhil Gokhale as co-chair, and we have eminent speakers with us from all over India who will be presenting their presentations. So I would request Vinit, can you please introduce our speakers?
Hi, good morning. This session is basically towards decoding the cornea related issues for general ophthalmologists. And to begin with, we will start decoding microbial keratitis and the know abouts and how to deal with them in day-to-day scenarios. And we have none other than Dr. Nikhil Gokhale, who has a huge amount of experience since the beginning in this region. And I would like to invite him to give a keynote on our first talk in microbial keratitis section. This will be followed by a series of sessions. We have chosen some specific topics which will be of keen interest to general ophthalmologists in the day-to-day clinics. So let's begin with our first session. Dr. Nikhil, over to you.
Thank you. I thank AIOS, Dr. Somashila, and all others involved in giving me this opportunity. So since this is for the general ophthalmologist, these are some of the thoughts that I put together. So whenever we sit in our clinics and we look at a patient who's got microbial keratitis, I think what we need to do is to go through these 10 steps, and each step is sub part of this talk, and I'll discuss each step further. So if we go through a very systematic approach and approach each step, we'll be probably much better in treating our patients in our day-to-day practice. I can't stress the fact that a detailed history of the present ulceration, the predisposing factors. Often patients have a lot of treatment before coming to us, so we need to look at what has happened, what has been the response, any previous episodes and systemic conditions. Always think, why did the patient get the ulcer in the first place? Look for risk factors, and many of these, when you introspect these factors, you would possibly know what is the cause, what are the organisms, what drugs may work well against them, and you could even predict the course of the disease as it progresses. And also very important to know about certain non-infective etiologies which you might pick up, which might be instrumental in the ulcer progression. I always stress that very often patients come to clinic with no sugar report done. Even if the patient denies diabetes or has a normal report a few months back, please do check blood sugar in all patients, irrespective of age and history. And of course, we need to look at other factors which might contribute to infectious disease. Documentation is extremely important. Hand-drawn diagrams are an excellent way because they provide an opportunity to learn the various findings that you see in an ulcer, and in a small practice help you monitor and see your ulcers as they progress or as they improve. And you need to follow a systematic way of drawing these diagrams, which are color coded, and also essential that do not put fluorescein before these diagrams are drawn or the pictures are taken. Digital pictures have a big advantage, especially when multiple people are involved in treating patients, and you can have an archive, and it is much better to document and compare images. However, even a drawing has their own advantages. For example, you could document certain things which may not be always easy to capture, especially with patients having a lot of photophobia. When it comes to diagnosis, typically the approach that we have is to use our clinical thought process and resort to microbiology. However, there are other options which are again having limited access, such as a PCR, a confocal, or sometimes a histopathology. When you look at practice patterns in practice, there are some doctors who would only do a workup and then treat them empirically with virtually no microbiology. Some of us might be able to do a smear test because it's very simple, doesn't need a big lab backup, and some of us might be able to do the whole gamut of smears and cultures. With all these restrictions that we know, we must understand that if we don't have access to microbiology, probably we should treat patients, some of these like this, which have severe infections, which have infections which are often drug resistance, and unusual infections or ulcers which progress rapidly and can cause blindness, to centers where these facilities are available. And there is no role of trying to do trial and error in some of these infections. Our clinical judgment is extremely important because this is the way that we are going to start a treatment even before the smear report is available. And the judgment is important because giving cocktail treatment to patients is less effective, reduces the compliance, and is more toxic, as we all know. And there are situations where the microbiology may be negative and we do not have any data, so we have to still stick to our clinical thought process. And also remember that in some situations, we have unreliable lab reports, and sometimes this can mislead us more unless we put our thoughts back and look at what is happening clinically. So as an average practitioner, I think if we can figure out what's bacteria or fungus, maybe 90% of our ulcers we would be able to manage. However, even in the best hands, to distinguish these two entities is quite a task and a difficult process. So there are several clinical clues which we have been taught right from our residency. However, we need to understand that these typical descriptions are often lost when the patient has taken cocktail therapy for a few weeks and now lands up in your clinic, and that is why we need microbiology in these patients. So based on our thought process and clinical examination, we could start treatment depending on what we think it is, whether it's bacterial, fungal, and the problem comes when we have no clinical clues. It's very difficult to decide, but it's better to err on the side of maybe starting an antibiotic and waiting for the smear or the culture report unless we have strong suspicion of the pathology being a specific, let's say, fungal or a different etiology. We need to do microbiology because it helps to confirm the nature of infection, guide our treatment, and medico-legally it safeguards us from problems which may encounter in patients who progress despite all good efforts that we make. I think there is a change in the way microbiology is done today. So we need to scrape at the active edge, plate multiple media, and send it to somebody who is interested in looking at ocular microbiology, and typically at least do a grams KOH and basic media. And then when we have more unusual infections, look at different special stains and special culture media. And when we suspect unusual infections, we have to extend our microbiology workup to have these in our armamentarium. And of course, when reports are negative or there is a deep-seated infections, we need to do a biopsy to subject it to micro and a histopathology. With limited access, however, confocal microscopy in referral centers could still be a very good way of looking at and diagnosing cases where microbiology may be not able to pick these infections. And similarly, a PCR or molecular biology is something that is really evolving and very useful today in some of the situations. So we started something based on our clinical judgment, and within a few hours, normally we have a smear report which comes back from the lab. We know the smears are quick, extremely reliable, and based on that, we know what sort of organism we are looking at, and we can decide whether we need to give an antibiotic, antifungal, or whether even we can pick up unusual organisms from the smear. So they can be extremely useful, and based on the smear report, we could select what drops we need to use for the given patient. However, the problem will come that smears are often negative. So you have a patient, you started some drops, you got the report is negative, then what? So till you get the culture report, you have to see if the patient is getting better, maybe continue the same thing. If the patient is not improving, you have the option of either waiting till the culture is available. If even that is negative, then consider repeat microbiology or refer to a higher center. The sixth step is, of course, to look at what is the response to treatment. So we know the signs and symptoms to look at when a patient of ulcer comes, and this is where our daily drawings or pictures helps us to compare what's happening. Once we have the culture report, we need to see what to do. It's important to understand that clinical response to treatment is most important. If the patient is improving, do not change anything, just continue with it. However, if the patient is not improving, the report can definitely help us to select alternative medications which may be more effective. And sometimes it might help us to stop some medications which probably are not effective but just adding to the toxicity. And of course, when we have the sensitivity, we can use drugs or select drugs which are more effective. However, again, base your selection based on what has happened in the 48 to 72 hours till you got these reports. And even with fungus now, we have some options where we could prefer one drug over the other. So you're treating a patient based on clinical judgment, smear reports, culture reports, you're doing everything correctly, but this patient is still getting worse. So now you need to think, what could be the cause? Maybe there's a wrong line of treatment. It's not unusual to get a wrong report of fungus or a bacteria, and then you just close your eyes and treat the report based on what the report says. It could be an unusual infection, it could be drug resistance, there may be a high infection load, poor drug penetration, it could be because of poor compliance, toxicity. As I said, there could be non-infectious factors such as ocular surface disease or an immune-mediated process which we are not addressing, and there may be systemic disease which may be contributing to this. So just go through some of these factors. So for example, you need to figure out whether you're treating an infection which is not resolving, or you're treating now a component which is non-infectious in nature. So we all know that infection is knocked off, but there are non-infectious factors which is contributing to the ulcer not healing. Similarly, there could be immune-mediated factors which we may not have addressed, and there are many patients where there may be a multifactorial combination of these factors which is causing the ulcer not to heal. So if you have drug resistance, of course the sensitivity might tell us which drugs to select, and if we don't have drugs for that particular organism, we need to do a surgery at an early stage. And we often encounter resistance when we have hospital or post-surgical infections, patients with surface disease, repeated antibiotic use, and immunosuppressed in elderly population. Sometimes the in vitro sensitivity is good, but in vivo we find there is no response. So something like a pseudo-resistance might happen with organisms, say like nocardia, atypical mycobacteria, because of high load of infection, poor drug penetration, and these are slowly replicating organisms. And you can also have that if you have not addressed a nidus of infection like the sac, the infection may not come under control. Ophthalmologists often find it difficult to differentiate infiltration, inflammation, edema, haze, scarring, and the transition from infection to resolution is sometimes not well picked up or understood, and we continue to use hourly, half-hourly drops even when the infection has been knocked out, and then we end up in a situation of a non-healing surface. This is where, again, we need to be watchful whether what exactly is happening and why the ulcer is not healing. This patient was a post-MMG SJS patient, came to me with a total epithelial defect with an annular ring infiltrate with stromal melting, and he was putting 16 times moxifloxacin and 245 drops, all 16 times a day. So basically in this situation, we have to stop everything, give them lubricants, oral doxycycline, and the surface luckily healed, and I didn't need to do any intervention in this patient. So these can be tricky situations. What looks typically infective, microbiology was negative, and a high index of suspicion and clinical judgment and close observation is what is required. Toxicities typically might present like a PED or a stromal melt. You can have sterile hypopion, and all these factors are much more accentuated when you have an unhealthy ocular surface. So unhealthy ocular surface will easily pick up and develop toxic signs due to medication. Sometimes in patients with ulcers, we need to check corneal sensation, look for the tear film, lid lash problems. There may be a foreign body which has not been addressed. Sometimes we have to flip the lid to figure out that this is actually an allergy and not an infectious ulcer. So we can have several of these factors which, if not addressed or picked up, it just looks like an ulcer to an average clinician, and he keeps treating with antibiotic, but they do not seem to be getting better. So we need to figure out the non-infectious surface and immune pathologies. The step 9 is surgical management. So if you have a patient we know with a large melt or perforation, we of course do a therapeutic graft. Small perforations we might manage with a glue bandage lens, and in early, if we pick them up early with thinning, we could consider using collagenase inhibitors and tarsorrhaphy. Therapeutic PK is something that we often need to do when we get patients who are coming late with involvement of limbus, extension to sclera, or very deep anterior chamber involvement. And in these situations, it's always better to do it early rather than late and wait for end stage disease where it becomes very difficult to salvage. You could do a DALK or a PKP, and it's always wise, and you need to decide what's good in your hands and how deep the infection is. Some of the adjunctive management is not to use NSAIDs in corneal ulcers. They can cause epithelial breakdown and precipitate melts and perforations. You can always use collagenase inhibitors. Atropine is again something that we all need to remember to use. And anti-glaucoma medications, we avoid PG analogs normally. Steroids, though there are certain indications in at least in a private practice situation, in a non-institutional setup with limited resources, it's best avoided in all infectious ulcers, specifically never use in fungal, nocardia, and mycobacterial ulcers. In bacterial ulcers, once the infection is under control, you could consider them, but again, one needs to be extremely careful. Similarly, in acanthamoeba, in very selected cases, with experience, one might need to use steroids. Cross-linking is something that is evolving for certain drug-resistant infections and refractory cases. This is the last slide of my talk, but I'll just have 2 more slides or 3 more slides to show you, since we have fungus and bacteria are the predominant infectious etiologies, how do we manage? So this is based on the TST protocol, where typically when a fungal ulcer walks in, we start with topical natamycin. However, if the ulcer is extremely large or deep, we might consider using an oral azole with it. Similarly, patients who are post-graft or who have posterior segment involvement, limbal involvement, we might consider using an oral azole. If the response is poor, we typically add a second drug, which may be voriconazole. If the response continues to be poor, we have the option of using intrastromal or intracameral antifungals. And if still patient doesn't respond, consider doing a therapeutic keratoplasty. Similarly, in any of these ulcer patients, if the corneal surface is sloughing, there is thinning, perforation, probably instead of giving intracameral or intrastromal, which may not hold the tectonic strength of the cornea, it's better to straight away do a graft. Also today, when you look at an ulcer which is not healing, which looks fungal or has been reported as having some filaments, rule out pythium infection, because this is something that might be not the basic reason why the patient isn't improving. So this is one algorithm for bacterial keratitis which I try to follow in my clinic, where we have small ulcers, peripheral, not really fulminant. You can use monotherapy. However, if they're large ulcers or fulminant ulcers, then you have to do smears, as I said, or some sort of microbiology. If the smears are also negative, use fortified standard combination therapy. If the smears are positive, look at what your clinical judgment and smears, whether they match or not. If they do not correlate, use standard therapy. If they do correlate, you can look at what is the risk of drug resistance in that given patient. If the drug resistant risk is low, you can use your regular antibiotics. However, if it's high, you should try to add a higher generation antibiotic in the treatment regimen. And as I said, when you have culture reports, if the patient is clinically improving, don't change anything or use or eliminate the ineffective drugs or replace with more effective drugs. However, if the patient is worsening, you can change as per the reports. Just to give you an example, for example, you have a large contact lens ulcer with pseudomonas, clinically feels like pseudomonas, smears are GNB. The resistance risk that you feel may be low, maybe because it's community acquired. You could use 2 antibiotics which work well against gram-negative organisms. On the contrary, if you have this patient coming from the ICU or from a hospital environment where there is a very high chance of having drug resistance in these gram-negative bacilli, you could consider using a higher generation of antibiotic from day one, because you have very little time to sort of lose. Similarly, you could have, so based on basically the risk of resistance, in situations where there's a very high risk of having resistant organisms, you could consider using a higher generation of antibiotic right at the go. However, these type of protocols are something which are not validated. So it's just a thought process that I've put forward. Each of us has to decide in our own practice what works best with the resources that we have, so that we are able to manage our patients better. And whenever in doubt, it's always wise to send the patient across either for a second opinion or to a higher center where they can manage these cases better than what we can all do. Thank you, and I would hand over the mic now.
That was a wonderful presentation, sir. Very crisp and very comprehensive. I would request Dr. Paris to please comment on the.
In fact, Dr. Nikhil has covered this topic extensively. I just have few comments, especially as general ophthalmologist, when you are treating a corneal ulcer. Observe the response for a couple of days, and it's very important also to familiarize yourself to clinical presentations, so that you can direct your management accordingly. And if the patient is not responding in a couple of days, maybe you could think of getting a microbiology workup done. That is not very difficult, as Dr. Nikhil pointed out in his talk very clearly. It is very easy to follow and very easy to reach a microbiologist and have these investigations done. And probably your line of management would be much appropriate. And still, if your patient is not responding, maybe that would be the time to refer them early on to prevent possible, visual loss, or, ending up in a major, troubles. So very extensively covered, Nikhil. Thank you.
Thank you, Dr. Nikhil. Next, I would like to invite Dr. Bhupesh Vagga. He's our senior cornea surgeon from LB Prasad Eye Institute, and he also heads the Ramoji Institute of Infectious Diseases and has been working on some cutting edge work in HSV keratitis. Would like to invite him to give his insights on the same.
Thank you. Thank you, IOS, for this opportunity, and Dr. Somshila and Kavya and Vineet for great coordination. So I'm going to discuss in coming 10 to 12 minutes about HSV keratitis. So herpes simplex virus, as we know, that is comprised of double standard DNA and is having a tegument made of proteins and envelope made of glycoproteins. In an updated classification, herpes virus comes under alpha herpes viridae, which has basically few genera like simplex virus and varicella virus. And in simplex, HSV1 and HSV2 are the viruses which I'm going to discuss in clinical implications here. But otherwise, for ophthalmological point of view, all the viruses which are highlighted here can cause sort of virus keratitis. Herpes simplex virus, if you think about that, this is not very common. So think about this epidemiology, which is from Western countries. It remains a leading cause of infectious cause of blindness worldwide. But there is 1 to 1.5 million new and 9 million recurrent cases every year, which is causing 40,000 new cases of severe visual ocular morbidity. And in more or less, which is very important in per se, and which is differentiating from other causes of infections from herpes, is primary and recurrent form, because of its predilection for trigeminal ganglion and cause of mode of transmission from anterograde as well as retrograde. This is data from LVP, which special paper is under review. From 12 to 2020, we saw around 8,308 patients, and in that, basically there are subgroups which are going to be analyzed. But in that, you can see 92.91% is the urinary involvement. In our series, the most common is stromal keratitis followed by epithelial keratitis, which is little contrary as compared to the published series. But overall, this is maybe the pattern of herpes keratitis which we see here, because many of the epithelial keratitis are self-resolving. Diagnosis is mainly clinical, but still we need some investigations in cases which are doubtful, or in terms of corneal scraping or anterior chamber tap. So there are 3 investigations which are going to be useful in terms of PCR, GMSA staining, and IFA in terms of indirect form of immunofluorescence. As you can see here, multinucleate giant cells in the GMSA, which is basically making the diagnosis susceptible, and also the IFA and PCR, but none of them is single-handedly used to make diagnosis. So the combination PCR and IFA holds maximum sensitivity and gives better as compared to IFA and GMSA and PCR and GMSA. So if it is available in your nearby lab, and you are having a doubtful case, which case is like almost negative in all microbiology, is always better to do corneal scraping or send for PCR and send for GMSA or IFA and combine it to confirm the diagnosis. You can also made by cell line culture. Like here you can see the spindle-shaped cells, like these are the human corneal epithelial cells which is on infection. You can see the cells become rounding and the space between them is increasing. So that's how it, and also you can make it like immunofluorescence on these infected cells. So what are the issues with the HSV keratitis? The evidence versus eminence versus translational conflicts because of lack of real incidence from developing countries, poor or not commonly available diagnostic indicators. Clinical classification is not very well defined, which is layer from years we are using that classification. HETS trial has been done to rule out for most common type of piece, but not including all the clinical variations. There are high recurrences with lack of data about that, and agreement of treatment across cornea specialists. So what is the clinical manifestations of HSV? Historically, we are basically managing like dendritic, geographical, immune stromal, interstitial, pneumolar. These are the terms which are being used in clinic. But the classification which I prefer and which is like which always good and very simple is based upon the anatomical involvement, like epithelial, stromal without ulceration, stromal with ulceration, and endothelial involvement, which is always, which gives me a little easier and also understandable because the way it is being managed is based upon this involvement. So I'm going to some cases. This is a 25-year-old female with a history of pain, foreign body sensation from 2 weeks using moxifloxacin eye drop 6 times a day. And if you see closely on the epithelium, you can see some sort of dendritic lesions with, if you stain it, it becomes very obvious. So it's very important to stain this type of ulcer or this type of lesion. You see there's a positivity from rose bengal as well as fluorescent. So that's the base is by fluorescent and boundary is by epithelial. And on 2 weeks of follow-up, this is almost disappearance with little bit of subepithelial haze. So treatment is well defined for this type of lesion. Topical antivirals in types of vidarabine, trifluridine, acyclovir. But in our scenario, we are commercially available acyclovir ointment and acyclovir ointment for 2 to 3 weeks, 3 weeks minimum if we recommend it. But the most important thing is no steroids because this is a contraindicated. Manual debridement has some role, topical interferon also some role, but they are not completely able to eradicate, so you need antiviral for this with proven effect. Like this case of keratitis presented to us, yeah. So this is basically, we can see there is a geographical lesion with previous vascularized scar, and based upon that antivirals were started, but topical corticosteroids were also added, and this landed up into a sort of necrotizing stromal keratitis. So this is one always lesson to everybody that if you are dealing with geographical ulcer or dendritic ulcer, recommend not to use corticosteroids because then the cornea can behave like that. And fortunately for this patient, we could save the eye by doing a patch graft and later on then keratoplasty. So this is another which is most common way in our series, stromal keratitis without ulceration. So this is the typical scenario. This is a history of blurred vision with white opacity in the right eye. Patient complains of like that, with no pain, redness, no photophobia or minimal photophobia, no epithelial defects, stromal edema is present, but no KPs and no AC reaction. So this is how it presents. OCT, you can see the corneal thickness is increasing with typical loss of the concavity of the cornea from behind. So that's how it presents, and that is basically make it different from other modality where the corneal edema presents. And this is the treatment is topical corticosteroids with gradual tapering, and you can see the response in 3 weeks is dramatic response with oral acyclovir should be given in prophylactic dose to avoid epithelial recurrence. This is the second variety with the stromal keratitis with ulceration, where the presence is like this. Difficult to differentiate from other causes of microbial keratitis. So definitely you should rule out by corneal scooping, and as Dr. Nikhil described about the microbiological workup. And this patient was having a recurrent history. You can see you should look for other telltale signs of herpes viral keratitis like vascularization or iris atrophy. Like this guy was having iris atrophy, central focal stromal infiltrate with overlying epithelial defect and sectoral iris atrophy. So this we suspected, and we did IFA and PCR also came out to be positive. We started oral acyclovir and then later on added topical steroids and resolved in 2 weeks' time. Here you can see better iris atrophy patch. So this was the way it is being managed as NSK or necrotizing stromal keratitis when the history of recurrence, wide granular interior to mid stroma infiltrates, overlying epithelial defect, presence of ghost scars, neurotrophic cornea, vascularization. Other microbiological workup is negative. Try to fix it with IFA and PCR. Even if it's not, try oral dose of acyclovir and assess the response and then add topical corticosteroids. Other modality which is not covered by HEADS is endotheliitis, like a history of 40, this is a 40-year-old male with recurrent episodes of pain and redness. As compared to immune stromal, patient will have severe photophobia and TH chamber inflammation is minimal as compared to other types of uveitis where you see multiple white KPs and which is very characteristic, this is underlying the area of edema. So you won't see beyond the area of edema, and that's the way endotheliitis presents. You can see in the OCT as well as those big KPs, and this is the type of you can say sectoral or disciform endotheliitis. The other form is diffuse endotheliitis, which is a type of diffuse corneal edema and often being diagnosed as toxic keratitis or corneal endothelial dystrophy, and many a time this being diagnosed as corneal edema. If at all patient is having pseudophakic also and advice for going for some sort of endothelial keratoplasty, but we need to look for the history and careful documentation of fine KPs behind those endothelium, and this patient respond usually with topical corticosteroid. We need intensive dose, not 4 times or 6 times. We need at least 2 hourly dose of intensive topical corticosteroids with full oral antivirals 5 times a day for at least 3 to 4 weeks. This is not very common to see, but often misdiagnosed HSV sclerokeratitis. Like this patient was having history of off and on redness and pain from past 2 to 3 years with no history of systemic disease, and very importantly this is having posterior stromal cellularity, not the anterior stromal, with no obvious epithelial lesions, and they respond beautifully with topical and oral corticosteroids, and you see classical crystalline deposits in the posterior stroma if they resolve. If you see this type of posterior stromal crystalline deposits, always make a red flag sign this patient might be having some form of sclerokeratitis, and do not operate without under cover of anticyclovir. So this patient of having graft for corneal scar, in 1.5 years, he came with photophobia, and when we got it, dendritic lesions on the graft host junction. This is the typical recurrence of herpes on the graft, which responds with nicely if you stop steroids and add topical and oral oral antivirals. And this is another variety of epithelial keratitis, which is marginal keratitis, and this is the only type of marginal or epithelial keratitis where topical corticosteroids has been indicated, and the response is many times good. And this is another way where the chronic herpes keratitis with the deep vessels, leash of deep vessels presents, and you see if there usually comes with a quiescent eye with mild ongoing inflammation, like in terms of stromal edema and little bit ceruleity and lipid keratopathy. So treatment is continuation of antivirals with the low dose of corticosteroids, but later on you can do fine needle diathermy of these vessels, and the response is sometimes so gratifying that you don't need any transplantation, particularly for these type of cornea. This is not always so simple. Sometimes appearances are deceptive. Like this guy was presented to us like a white capes and stromal edema. We suspected in terms of fungal endotheliitis or fungal posterior stromal lesions. We did endoscoping and intracameral voriconazole. But there was no organisms on follow-up, so we started thinking in line of viral. We did do at the time EC-TEF for ruling out viral keratitis, but we started separate trial of antivirals and assessed the response. The response was quite gratifying when we added steroids, and it actually responded so nicely. The same time, similar time, 1 week later, this patient came and came like this, also came out to be negative on microbiologically, and so we started again oral cyclovir and steroid. This patient also responded nicely, but after 2 weeks, this patient came with the worsening of infiltrate, and it came out to be fungus. So the lesson learned is we need to rule out it, but keep the patient under close follow-up. And when you see this carpet-like capes as compared to endotheliitis, think about viral etiology as compared to this type of bunch of exudates along with like capes looking like capes on desmet. Can it be a fungus, and need to rule out and keep the patient under very, very close follow-up. Fortunately, this patient managed nicely with the help of keratoplasty. So thanks for the opportunity. I would end with my talk with this.
That was again a wonderful presentation, sir. And it's always been a pleasure to listen to you. And as we are running short of time, we will be taking questions at the end of the session.
Next, we have Dr. Shilpa Dharini. She is our young dynamic cornea faculty in Vizag Center of LBPI, and she'll be taking us through how to manage smaller perforations and applications of TA, tissue adhesives. Over to you, Shilpa.
A very good morning to the dignitaries on the dais, and a good morning to everyone. First of all, I would like to thank Dr. Somashila for the opportunity, and also Dr. Kavya for helping with the videos. Yeah. So we'll look at how to manage small perforations using tissue adhesives. So when we perform therapeutic penetrating keratoplasty in a perforated corneal ulcer, which is usually of larger size, the graft tends to fail early, and an endothelial keratoplasty or an optical penetrating keratoplasty becomes mandatory later on. But when you have a smaller perforation, you can get away by doing a glue BCL, and later on you can perform an optical penetrating keratoplasty, which will eventually have a better outcome compared to a therapeutic penetrating keratoplasty. So what tissue adhesives are available? We have synthetic polymer-based adhesives available. We have the naturally derived polymer-based adhesives, which are fibrin-based tissue adhesives. So the synthetic polymer-based adhesives are the cyanoacrylate, polyethylene glycol-based, and dendrimer-based adhesives. But the commonly used ones are the cyanoacrylate-based tissue adhesives. So look at what are the advantages of the cyanoacrylate tissue adhesives. So it is more effective when we use the tissue cyanoacrylate in perforations lesser than 2 mm, but it is also useful in perforations up to 3 mm size. And it mainly provides tectonic stability, avoiding the need for keratoplasty later on. It inhibits collagenolysis, proteolysis, and stromal melting. Also, it is shown that tissue cyanoacrylate exhibits bacteriostatic effect on gram-positive bacteria. So cyanoacrylate may not be an ideal tissue adhesive. We do have some disadvantages. It is not useful when the perforation is too large, and it exhibits some cytotoxicity. So when it enters care should be taken that it should not enter the anterior chamber. Cyanoacrylate glue invites deep corneal vascularization, which leads to poor survival, graft survival outcomes later on. Cyanoacrylate rapidly polymerizes when it comes in contact with any body fluid. So an irregular rough surface is created, which makes applying a glue BCL later on mandatory. So when to apply tissue adhesive? So when you have a perforation, as said, less than 2 mm more effective, and up to 3 mm you can manage. When you have a decimetocele or an impending perforation, when you have a persistent epithelial defect with stromal thinning, when you have active collagenolysis. So the first two, the perforation and the decimetocele, should be performed in an operating room, while the last two, the stromal thinning cases and the active collagenolysis, you can perform them in your own OPD setup. So what all do you need to perform a glue BCL? So first of all, the commercially available ones, you will get the tissue adhesive solution in a vial. A 1 ml syringe will come along with it. A needle will be there. So we have to load the solution into the syringe, and either using a Vexel sponge or a 26 gauge needle, you can apply the tissue adhesive on the area of thinning or the perforation. And later on, after the polymerization happens, you can apply the BCL. So let us look at how the actual technique is performed. Epithelial debridement is mandatory because the tissue adhesive does not stick to intact epithelium. So using a surgical sponge, you can just raise the loose epithelium around the area of infiltrate. You can also use a non-tooth straight forceps to peel off the epithelium. Or use a 15 size blade to scrape off the epithelium. Especially in post-PK PEDs or in ocular surface cases, do not peel off too much of epithelium to avoid poor healing, epithelial healing later on. Apply the glue as a thin film over the area of thinning. Do not apply excessive TA. After the polymerization is complete, apply the BCL. So this is how you can, these are all the techniques how to apply the tissue adhesive. A surgical sponge can be used. A 26 gauge needle can be used. It is advisable to not touch the tissue adhesive immediately after application to avoid peaking of the tissue adhesive. You can also use iris repositor. Also, it is advisable to not apply too much of tissue adhesive to avoid mound formation, especially in decimetocele and in large perforations. The bandage contact lens will not sit properly on the tissue adhesive and will lead to poor patient tolerability and later on papillary hyperplasia in the upper tarsal conjunctiva. So one important thing is to dab the backside of the Vexel sponge on a dry surface twice or thrice to avoid excessive application onto the surface, corneal surface. So next step is forming the anterior chamber. So while making the side port, it is advisable not to hold the limbus at the opposite side of the side port. This will lead to collapse of the hypotenuse globe and reopening of the perforation. So instead, it is better to hold at the same site where we are planning to make the side port and direct the MVR knife vertically into the anterior chamber. So finally, let us look at how a perfect glue BCL and AC reformation is done. This is a 41-year-old female with fungal keratitis. The patient was taken to the operating room. The epithelium was debrided around the area of perforation. The area of perforation was noted. The tissue adhesive was applied. Immediately, the sponge is retracted back, and this should be avoided. Touching the glue immediately without drying is avoided to avoid peaking of the tissue adhesive. A 26 gauge needle was used. The areas of peaking were trimmed off using Vanna scissors. Using a 29 gauge needle, anterior chamber was formed and later on replaced with saline. And checked for any leak. The BCL is finally placed. And this is the post-operative outcome with the full formed anterior chamber. Yeah, thank you. Thanks for the opportunity.
Thank you so much, Dr. Tarini. The tips and tricks that you shared were really useful, and I hope that would be useful for everybody. Now I would request Dr. Kavya to please come on the dais.
Dr. Kavya is our cornea faculty from LV Prasad Eye Institute, Hyderabad branch, and she also takes a keen interest in microbial keratitis. And she'll be taking us through some uncommon infections and the approach towards them. Over to you, Kavya.
Yeah. Thank you, Vineet and Dr. Prabhakar, for the introduction, and would like to thank Dr. Somashila and AIOC again for this opportunity. So now that we've gone through all the common cases that we see, I will quickly over the next few minutes take you through some uncommon cases of microbial keratitis that you might come across in your practice. So like Dr. Nikhil very beautifully described to us about how we approach cases of typical fungal bacterial keratitis, and Dr. Bhupesh took us through HSV keratitis, but there are certain situations where you face some uncommon organisms with atypical clinical presentations. So one is always stuck with the dilemma as to how to proceed with these situations. In a recent publication in the Ocular Surface Journal by Jodhbir Mehta's group, it was noted that only 1 in around 20 cases are unusual pathogens, and these are invariably associated with worse visual prognosis and ocular morbidity. A main reason for this is because they occur in the context of previous traumatic injuries or surgeries. They have a higher risk of misdiagnosis and delay in initiating the treatment, the presence of the organisms that are insensitive to the current ongoing therapy, a possibility of mixed infections, and inadequate or poor compliance to treatment. So when do you need to have a high index of suspicion? When a patient presents to you with a history of travel to countries with known higher prevalence of certain unusual infections, when the trauma is from either soil or vegetative matter, patients who have had recent corneal surgeries including laser refractive surgery, and if any history of local or systemic immune defenses are compromised. So I'll take you through a couple of cases to help us understand this better. This was a 26-year-old armed force personnel who came to us from West Bengal with a diminution of vision in the left eye since 8 months. He presented with a very vague history of on and off episodes of pain and redness in the left eye, and had one contributing factor of a fall of insect prior to the onset of his symptoms. He kept consulting locally throughout the period where he was prescribed medications of which the details were not available. When he came to us, he was on topical steroids, cycloplegics, and topical antivirals. This was his clinical picture. As we can see here, there is a large crescentic area of anterior to mid-stromal infiltration with a leash of superficial vessels extending from one end of the limbus to the central cornea. We can also see some area of lipid keratopathy over here. So when he came to us with this picture, we also on careful examination noted that some amount of stromal edema was present both inferiorly as well as superiorly. So with this diagnosis, we again continued the patient. There was no scrapable lesion, so we continued the patient on the ongoing therapy of topical steroids and antivirals. He came back to us 1 month later with significant worsening. We can see there's a definite increase in the intensity of the infiltration, and there was the appearance of some pigmented keratic precipitates inferiorly. We rechecked his compliance to medications, and we noted that there was a definite worsening on topical steroids. So now you have to consider the differential diagnosis. So when you have a long-standing microbial keratitis, it could either be a nocardia keratitis, fungal keratitis, or acanthamoeba keratitis with such atypical presentation. But either of these are unlikely to have such an indolent course while the patient is on topical steroids. The next consideration is atypical mycobacterial keratitis or microsporidia keratitis. But however, both of these have either a waxing and waning course, and this intense vascularization as was seen in this patient is not typical. So in any such cases of doubt, always go ahead with a corneal scraping with the full armamentarium, smear, culture. IFA was sent for HSV antigen and PCR as well. Surprisingly, in this patient, we got this smear report of partially to gram-positive beaded, partially stained or unstained bacilli in the gram stain. So as we can see here, these are not very easily identifiable. You need a more experienced microbiologist to take you through this, and it's very easy to be missed. This can be confirmed again with a 20% acid-fast staining or the modified Zeal-Nielsen staining. So here we can see clearly slender, long beaded, non-branching acid-fast bacilli suggestive of mycobacteria. It's important here to note the percentage. A 20% H2SO4 stain is needed for AFP. So with this diagnosis, now the patient was started on fortified amikacin drops and was called after 2 days to confirm the IFA PCR reports as well. This is the culture. It is very remarkable to note that they have characteristic confluent white raised colonies, and the culture smear done also confirmed mycobacteria. His IFA and PCR was negative for HSV. The susceptibility is very limited. They are sensitive to drugs like amikacin and moxifloxacin. So a quick review of atypical mycobacteria. The typical clinical features are they have a typical waxing and waning course of the disease, usually a central white stromal infiltrate, and what is described as a cracked windshield appearance. This may be not easily picked up in all cases, and significantly worsening on topical steroids is a characteristic history. The diagnosis is usually confirmed with Gram stain and Ziel-Nielsen stain 20%, and culture on LJ medium, Middlebrook medium, and MGIT. Newer diagnostic methods are also available like PCR analysis, gene sequencing, nuclear acid probes, and MALDI-TOF. For our patient, we went ahead and did the MALDI-TOF as well, and the species was identified as Mycobacterium abscessus. Over a period of the next 2 months, he gradually improved on amikacin, and on his last follow-up, we saw a completely scarred and vascularized cornea. So Mycobacterium abscessus, a quick note about it, it is generally a multi-drug resistant organism, but luckily it is susceptible to amikacin in our patient, and a couple of cases that we have seen over the last few years. This is another case of atypical mycobacteria. This patient presented to us with vague history of congestion over a pre-existing scar. As we can see over here, there is an anterior stromal infiltrate with some DM folds around it, which could be mistaken for a cracked windshield appearance. So here the scraping again showed us unstained thin long bacilli, and acid-fast bacilli was seen on 20% AFP stain. He was started on fortified amikacin and atropine eye drops, and over the period of 4 months, he completely resolved infection. So again, to stress some take-home points, these are generally fastidious organisms, difficult to treat. Antibiotic resistance in species like Mycobacterium abscessus can pose significant challenges in management, and in difficult cases, newer diagnostic methods like MALDI-TOF can prove useful adjuncts. So we'll move on to the next organism. With this case, this is a 17-year-old male who came to us with blurring of vision in his left eye since 2 months following a history of trauma. And he had consulted elsewhere and was on treatment with topical antivirals, but due to no response, he had stopped all medications. The scraping was done, which showed thin beaded gram-positive branching filaments suggestive of actinomycetes. So here I'll take you through again some characteristic clinical features of these. The acid-fast staining was done, which was 1%, where we saw acid-fast filaments suggestive of nocardia. And here fortified amikacin was again started. So this is the image of the gram-positive beaded bacilli, which is very different from what we saw earlier in the atypical mycobacteria. So this patient was continued on amikacin, and over a period of 25 days, anterior stromal scarring was noted and amikacin was stopped. Nocardia are gram-positive non-motile branching filamentous bacteria. Several species are of human clinical significance, and the most common are the Nova complex abscessus and some difficult to treat species like Brasiliensis. The predisposing factors for infection are trauma, contact lens wear, previous surgeries, use of corticosteroids. This is the clinical features mainly are white patchy infiltrates, which are predominantly anterior stromal. They are surrounding yellow discrete pin-headed sized lesions which will be surrounding the main infiltrate, and which is typically described as a wreath pattern. So these, if you see a patient presenting with this, an immediate clinical suspicion of nocardia must be taken in consideration, and also request your microbiologist to do an acid-fast staining to confirm the diagnosis. Some atypical signs that may not be associated are pseudodendritic lesions, presence of a PED, subepithelial involvement, a white stromal opacity, either a full thickness or a deep stromal infiltrate, or an endothelial plaque. Usually, the culture grows on both blood and chocolate agar, and on prolonged incubation, the colonies appear waxy and hard with a velvety surface. PCR can also be used for diagnosis. Nocardia can also commonly present as scleritis, especially in patients who have undergone previous surgery. This was a 64-year-old male who had come with combined cataract and trab surgery. And as you can see here, he developed a yellowish scleral nodule adjacent to the site of the previous filtering surgery. He had consulted elsewhere where he was on treatment with antivirals, but he had again stopped medications. A scleral deroofing is mandatory in these patients to ascertain a microbiological cause. And post the deroofing, we again saw thin branched filaments suggestive of actinomycetes, which was confirmed on acid-fast staining as well. The patient was started on amikacin and oral ciprofloxacin, and over a period of 3 weeks, he improved with conjunctivalization. So nocardia scleritis is usually rare and occurs primarily because of extension of corneal infection from the limbus. The predisposing factors are any infected cataract surgeries, exposed scleral buckle and trauma, and they also have areas of necrosis, thinning and discharge. Generally, nocardia responds very well to treatment with amikacin and a combination of trimethoprim sulfamethoxazole. Surgical management in cases of scleritis may be essential to a certain diagnosis. We'll quickly move on to acanthamoeba keratitis. This was a patient who presented to us. She was a contact lens wearer and presented to us with a 1-week history of pain and redness. Here we can see a very characteristic ring-shaped infiltrate involving the anterior to mid stroma. The scraping showed acanthamoeba cysts, and the patient was started on topical PHMB and chlorhexidine. Over a period of, the culture also grew acanthamoeba. Over a period of the next few weeks, we also started her on topical steroids after two weeks of initiation of anti-acanthamoeba therapy. And finally, she responded well, and this was the final picture at 7 months. So this patient shows that how a good response and good clinical diagnosis can help you cure acanthamoeba over a longer period. So some of the classical features of acanthamoeba keratitis is the characteristic ring infiltrate and also radial keratoneuritis. Acanthamoeba is notorious in that it is a great mimicker and it is easy to misdiagnose, especially with cases of HSV necrotizing stromal keratitis and even in some cases of fungal keratitis. Always use steroids with a lot of caution. It is indicated only in patients who have very deep corneal vascularization, inflammatory complications of scleritis, limbitis, and severe out of proportion pain. The guidelines which should be followed are that it should be started only after completion of 2 weeks of biguanide therapy. Antiamoebic therapy should be maintained throughout. Watch carefully for any signs of recurrences. Steroids can be continued in a low dose until the inflammation is controlled, but the biguanides should be continued for at least 4 weeks after discontinuation of steroid therapy. So I'll just skip this case and go to the last one. So a quick note on pythium keratitis. We know that pythium keratitis is a newly emerging, very common infection, and it is easy to be misdiagnosed with fungal keratitis. So few points that should be kept in mind in your clinic is some characteristic features like the anterior stromal and epithelial involvement with radial, tentacular extensions in the periphery. The smear characteristically shows ribbon-like folds of sparsely septate or aseptate filaments, and the culture shows flat, featureless, partially submerged colonies. The histopathology can also help in identifying between pythium and fungus. It is especially easy to be confused with fungal keratitis, suspected when a patient is not improving with antifungals. KOH stain helps in diagnosis, especially with calcofluor white. It also can be diagnosed with GMS and culture, and antipythium medical management includes linezolid and azithromycin. So to conclude, the take-home message is these atypical organisms can have variable clinical presentation. Some have unique features, but most of them do help resemble bacterial or fungal keratitis, which can confuse you in a busy clinic. They do have a variable response to our routine treatment strategies, which should raise a red flag. A high index of clinical suspicion is mandatory to make a correct diagnosis and to work in conjunction with your microbiologist to suspect that particular organism. And early and prompt diagnosis improves outcomes drastically. Thank you very much for your patient listening.
Great collection of cases, Kavya, and very well documented cases. Wonderful presentation.
By the time Prabhakar loads up, any comments from our panel on the atypical presentation and management of these cases in OPD and management of small perforations, as Shilpa had mentioned? Any comments from?
Also, I think we need to keep in mind that many of the patients that we diagnose as viral, and if we keep treating with steroids and they don't seem to be getting better or getting a quick recurrence, sometimes in our practice we find these are microsporidial infections, which we probably didn't cover up a little bit, but any unusual looking virus which you're trying to treat and looks granular and tends to recur as soon as you stop steroids, I think we need to keep that in mind and have a high index of suspicion. So
Any tips on application of TABCL and dealing with smaller
Yeah, I think
perforations?
beautiful videos, very nice videos that she showed us. So I think one thing that we need to do whenever we apply BCL, as was highlighted, is to have an epithelial debridement around the area of the ulcer, so that we have some healthy stroma on which the glue is going to sort of stick. So it's like a flyover bridging a weak area. So if you don't de-epithelize, but which can be also tricky, sometimes in a very thin cornea, trying to de-epithelize, you might rip apart the whole tissue there. So very carefully need to remove the epithelium and then apply a thin layer of glue. The thinner the better. And I think that Vexel sponge reminds me of my fellowship. I think we did the same thing 25 years back.
Thank you for those inputs. So now I invite Dr. Prabhakar Singh, my co-moderator. He is practicing as a cornea faculty in AIMS Patna, and he will take us through managing how to deal with intrastromal and intracameral injections, and basically how to deal with these formulations.
Good morning once again. So the title here is Intrastromal and Intracameral Antimicrobial Injections. When, why, when, and how. So when I say intrastromal and intracameral antimicrobial agent, I would largely imply antifungals, and I have no financial interest to disclose. To label a keratitis as a case of fungal keratitis, we have to have either a smear positive or it has to be culture positive. And following are the drugs in the armamentarium of the cornea specialist. These are the topical medications that we use, and these medications work quite well. However, at times these medications do not work and our ulcer tend to worsen either because of there is deeper stromal involvement, there is associated severe anterior chamber reaction, or the drug is not reaching the intended site. So what has to be done then? So this is the time when you have to devise a targeted delivery system, either in the form of intracameral injection or intrastromal injection. Why? Because this gives you an advantage of giving, the drug reaches to the intended site and gives the maximum bioavailability. However, there is potential risk of spread of infection to the deeper tissues, and there's also a risk of seeding of the entry port. There are various studies in the literature which suggest that these intrastromal injections of antifungal agents are quite safe and effective, especially in cases of recalcitrant fungal keratitis. So with this, I would like to take you through the preparation of various drugs that are being used as intrastromal or intracameral injections. So let's first start with voriconazole. So while preparing a voriconazole eye drop, the 50 microgram intracameral or intrastromal dose, you can prepare it either from the voriconazole eye drop that is available as 1% drop by Orolam, or you can just take the voriconazole injection 200 milligram vial. Let's first talk about the one that we prepare from the vial. So it comes in a form in a strength of 200 milligram. What you have to do is you just have to do double dilution. First, add 19 ml of ringer lactate solution to it. The resultant solution, take 1 ml of that and again dilute it with 20 ml of ringer lactate solution. Now the solution that you will be having will have a concentration of 50 microgram per 0.1 ml. Say if you have access to the eye drop, the voriconazole eye drop, 1%, then again you just take 1 ml of that solution and add 20 ml of ringer lactate solution, and the resulting solution will have a concentration of 50 microgram per 0.1 ml. When it comes to preparation of amphotericin B, it comes in a vial of 50 milligram. Just take a 50 milligram vial, add 10 ml of 5% dextrose to it, and the resultant solution, take 0.1 ml of it and again add 9.9 ml of 5% dextrose, and the solution is ready with a concentration of 5 microgram per 0.1 ml. There are various preparations now available for netamycin also in the form of netasol, though I have a limited experience, so I have not talked much about it. Now, once we have discussed the preparation of the drugs, let's talk about as to when do we need to go for intracameral injection and when we want to give intrastromal injection. I would like to take you through a small case. This is a case wherein, you can see that there is a large central corneal scar and there is superior patch of endothelial exudate. And there is anterior chamber reaction in the form of a hypopion, and there are superficial and deep vessels also. So considering the fact that the epithelium is intact, the efficacy of topical medications, the topical medications won't be able to reach the anterior chamber, but the infection is largely in the anterior chamber. So what has to be done? Here we made a diagnosis after doing an endoscraping, and the endoscrapings were subjected to microbiological evaluation, which revealed fungal filaments. And this is when we planned for giving intrastromal antifungal agents. And this is the outcome after 3 doses of antifungal agents that we had given intracamerally. Now coming to the second scenario, here you can see 2 clinical pictures. In both the pictures, you can see that there are large corneal infiltrate. In the first picture, you can see that the one on the this side, on the left side, you can see that the corneal infiltrate is pretty large, and it's of variable depth involving from superficial to deep, and you can see a thin sliver of clear cornea all around, and specifically it is threatening the inferior and the temporal limbus. Now what is to be done here? As the infiltrate is threatening the limbus and is very close to the limbus, if it involves the limbus, the outcome is definitely going to be downhill. So what we can do, and again, there is a paucity of corneal tissues. Ideal would be to go ahead and do a therapeutic penetrating keratoplasty for such patients with a clear margin. But considering the fact that there is a paucity of corneal tissues, and also there are not enough transplant centers, we can do our bit and give intrastromal injections. So this is a kind of desperate measure to prevent going it downhill, or to compromise the outcome, not to compromise the outcome. This is what we can do from our side. So this was a desperate measure here. Now coming to the clinical scenario, which is on the right side, again you can see that there is a large corneal infiltrate. There are multiple satellite lesions which are reaching the limbus, and you can see this superior part, which is the deep stromal involvement. These infiltrates had progressed in just a matter of 2 days and are threatening the superior limbus. Now here you have to make a timely decision. You have to select your case very carefully and make a timely decision before these infiltrates reach superiorly. Considering such a fast involvement, it's better to go ahead and do intrastromal injections here. So once we have talked about the preparation, we have talked about when to give intrastromal, where to give intracameral. Let's talk about as to how to go about it. So there is a study which talks about as to how to give intrastromal injections. In their study, they had shown that we can divide the cornea into 3 different zones, the outermost zone being zone 1, and the innermost being zone 3, and the intermediate zone as zone 2. So they said that you just have to enter the zone 3, traverse entirely the zone 1, and then enter zone 2, and this is where you have to inject your medication. And there is absolute no to the entry of needle to the zone 1. So here is a short video that I would like to show you as to how to give intrastromal voriconazole. Always remember that you have to be a little away from the infiltrate and start from the clear cornea and try to inject. So here you will be seeing that initially there is some sort of air injection which was there in the needle, and subsequently you can see a zone of hydration which ensures that the drug has been penetrated intracorneally. Always remember while giving the injection, the bevel should be up, and unless the entire bevel is intracorneal, don't inject. You also have to remember that the level at which you have to inject is the mid-stromal level. And whenever you want to come out, it's always better to take your plunger little out and then come out. This will prevent backflow of the drug. The infiltrate has to be barraged all around, and always take utmost care that you don't perforate the cornea or keep away from the thinned out cornea or thinned out area. And the endpoint is always where your barrage is complete. So with this, I would like to take you to the take-home message that intrastromal and intracameral injection is quite safe and effective, provided you have made an appropriate case selection and you have done it at an appropriate time. Thank you so much.
Thank you, Dr. Prabhakar. I think because we are falling short of time, any closing comments from our panelists?
Total. We just, it's not, I'm not very sure about as to how much volume in total, but we just have to infiltrate such that it makes a halo all around it. So you just have to infiltrate all around so that the barrage is complete. I'm not sure about the volume.
Yeah. In fact, all in all, we had a good session starting from, microbiological workup to, atypical organisms, how to, deal with them, and even the rarest procedures like, intrastromal injections from Prabhakar. So with this, I would like to, close the session, and we can move on to the next, part of the cornea session. Thank you.
मैम कौन सा है मैम कौन सा 10 वाले में ना 10 बजे वाले में ये वाला ना